And when I got there, the patient's on the ground. Her wife is with her. She's fanning her. The patient's pale, a little diaphoretic. Everyone's freaking out. But the patient's wife was calm and explained to the team, my wife has POTS. This happens all the time.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
Welcome back to the Rapid Response Run podcast. Today I have a special guest. Dr. Alexis Cutchins is a cardiologist at Emory and one of the authors of the journal article, Narrative Review of Postural Orthostatic Tachycardia Syndrome and Associated Conditions and Management Strategies. It is the best, most comprehensive, and easy to understand summary of POTS that I have found. So Dr. Cutchins, it is an honor to have you. Welcome to the podcast.
Thank you so much.
So my goal for this podcast is to provide kind of an overview of POTS and to teach nurses how to advocate for the best care of this patient population. Before we dive in, could you just introduce yourself and share how you got interested in caring for POTS patients as a cardiologist?
Sure. So as you said, my name is Alexis Cutchins. I've been a cardiologist at Emory for about 12 years. I have a sort of specialization in the cardiac care of women, and POTS sort of fell into my lap a little bit because I started seeing a lot of patients as an early attending with tachycardia, syncope, chest pain, and palpitations. And it turned out that many of these women had POTS. Over the years, I sort of developed an expertise in this area because I kept on seeing more and more of these patients and learning more and more about POTS, which is something I was never formally trained on in my med school or residency or fellowship training. So over the years, I've sort of developed a niche in this area because I think that I sort of understand this population of patients maybe in a way that other people don't.
Yeah. And I think that's because you listen, honestly. I think you're a good listener. And so you're tapping into symptoms that maybe other people would just blow off. So I want to share a quick story with you. And then from that story, kind of dive into like the pathophys of POTS. A few years ago, I responded to a rapid response call. And when I got there, the patient's on the ground. Her wife is with her. She's fanning her. The patient's pale, a little diaphoretic. Everyone's freaking out. But the patient's wife was calm and explained to the team, my wife has POTS. This happens all the time. We just need to fan her, give her a minute. But the doctors that responded, they did not know what POTS was. They're like, POTS, what? POTS? They were insistent we get a stat EKG and blood work. And the wife warned us, hey, she's a really hard stick. I assure you there's nothing wrong. This is not out of the ordinary for her. She just had her blood drawn 30 minutes ago. And I could sense from the medical team, they were getting kind of irritated with the wife of this patient. I don't know if it's because she knew more about POTS than they did, or because she was questioning the need for stat blood work, or because she was kind of in their way, like fanning the patient. I don't know, but their resistance was palpable. So the problem is I felt very ill-equipped to advocate for the patient myself in the moment because I didn't have enough knowledge about POTS to know what to suggest or how to respond to the patient's wife, except for thanking her for being there. So that night I went home and I researched the crap out of the pathophysiology of POTS. It was fascinating. But I also kept thinking, how many patients have I discharged from the ER with negative head CTs, negative blood work, negative EKGs? They said, you're fine. And they probably had POTS. So that is why I sought you out to be my podcast, because from everything that I've read from you, things you've wrote and presentations you've given, you stress the importance of listening to your patients and not dismissing their symptoms. And that is the perspective I want to learn from. So on that note, could you provide a brief overview of postural orthostatic tachycardia syndrome, or POTS. Like, what do we currently understand about this condition?
POTS is postural orthostatic tachycardia syndrome. And patients with POTS will find that the heart rate increases pretty dramatically when they're standing for a period of time. Usually, it's after a few minutes, but it can be right after standing. What's nuanced about POTS is that their blood pressure does not drop. In fact, some of these patients will have an increase in their blood pressure along with the increase in heart rate. But it's the high heart rate that causes them to get dizzy and to pass out. So in orthostatic hypotension, when you stand up, there's a drop in blood pressure. There's other forms of orthostatic intolerance, like inappropriate sinus tachycardia, which means that your heart rate is high most of the time and not necessarily high just with standing. But really in POTS, we're looking for an orthostatic intolerance that's related to heart rate. But of course, there's a spectrum here that these patients, there's sort of overlap in symptoms with inappropriate sinus tachycardia and orthostatic hypotension. And a lot of it is treated the same way. But if you're specifically talking about POTS, it's the elevation in heart rate, technically greater than 30 beats per minute over sitting or standing heart rate, with symptoms like dizziness, passing out, chest pain, shortness of breath, etc.
So what are some of the known or suspected causes or contributing factors to POTS? Like, are there any new theories or findings about POTS?
Yeah, so historically, POTS is considered a dysautonomia or a disorder of the autonomic nervous system. And that means that the autonomic nervous system isn't compensating appropriately when it should be. So with standing, you should have a response with standing of sort of clenching of the venous blood vessels and a little bump up in blood pressure and a mild bump up in heart rate. But this is all to compensate for shifts in blood volume when you go from lying down or sitting to standing. And those are appropriate. When you have an abnormal autonomic nervous system, then those signals may not occur properly. But there are other sort of factors going into play that cause POTS symptoms. The first thing I do when I see patients is try to eliminate other causes, other things that could cause you to have an orthostatic rise in heart rate, like anemia and iron deficiency and medications or thyroid abnormalities. So these are all things we try to exclude before we give someone a diagnosis of POTS. But now we're seeing a huge association of POTS with things like connective tissue disorders and hypermobility spectrum disorders like Ehlers-Danlos. And those patients also have a huge overlap of something called mast cell activation syndrome. And mast cell activation syndrome is an abnormality of the mast cells, which are those cells that produce histamine and other chemicals to respond to an allergic response. And you can imagine that in the most severe case of allergy or anaphylaxis, you get a drop in blood pressure and a rise in heart rate. And, patients sort of exhibit a lot of the symptoms that patients with POTS exhibit. And so there's a spectrum of mast cell activation syndrome that can also, when triggered, cause symptoms of high heart rate and dizziness and diaphoresis and, flushing and all these other things. So I think there's a lot of overlap there. And part of what I do is diagnose and treat mast cell activation syndrome while I'm also treating patients with POTS, and their POTS symptoms. But the other thing we're finding is many of these patients also have venous disease or abnormalities in the veins of the pelvis and the lower extremities, causing pooling of blood in the legs and the pelvis. And that can also contribute to decreased venous return and lack of cardiac output, causing tachycardia compensation, which then results in passing out or other symptoms, exercise intolerance, et cetera.
So obviously syncope is a big symptom that would bring someone into your care. Are there any other symptoms that you find are really common for this patient population?
From a cardiac standpoint, many of them have exercise intolerance and post-exertional malaise. They also have chest pain, which can often be actually associated with coronary vasospasm, but sometimes the chest pain is just a result of the high heart rate. They can have shortness of breath and shortness of breath with exertion, but shortness of breath at rest, like a feeling of air hunger, but also shortness of breath with exertion. So from a cardiac standpoint, that's sort of what we see. But they also have a lot of systemic symptoms. So GI symptoms like IBS, gastroparesis, reflux, dysphagia sometimes. And then there's also sort of a comorbidity of migraine and headaches, and then generalized pain, like chronic pain, sort of fibromyalgia symptoms.
Gotcha. So I can see why these patients might have a hard time coming to a diagnosis because the symptoms are so very kind of across the board. Everyone's very different. It's a spectrum. What do they come to you with? Are there any specific criteria or tests that you use to diagnose POTS? Any misconceptions or challenges in diagnosing this condition?
Yeah. So usually we rule out bad things. We want to make sure there's no bad arrhythmia happening. We do an event monitor or Holter monitor to make sure it's not something that can be fixed or something, treatable. And we often look at an echo to make sure the heart's structurally normal, and usually do some sort of stress testing, like an exercise treadmill test, to make sure that we're not inducing any other kind of rhythms. All of those tests always come back normal, essentially, except for the vent monitor, the Holter monitor, which may show high heart rates, but usually it's read as normal anyway, even if those high heart rates may be very relevant to the symptoms. And so from there, we sort of look at orthostatic testing. So specifically, we do orthostatics in the office. We get lying, sitting, and standing blood pressures and heart rates. There's also something called the NASA lean test, which can be done at home for patients who want to figure out if they have a diagnosis of POTS, and that can be found on the internet, but you can, it's like a 10-minute stand sort of test. And that's very helpful because patients can repeat it a couple of times. The classic test to diagnose POTS is a tilt table test. And that's something we do in our office, but there's basically bed that gets tilted up, and we have the patients lie on the bed in the tilted position until they develop symptoms or pass out. We monitor their heart rate and their blood pressure in regular intervals. The hiccup or the problems that I find with the tilt table test is that sometimes it comes back as quote unquote normal. And then there's a patient who has all these symptoms of POTS and who very much meets many criteria for POTS, but has a normal diagnostic test. And so they get labeled as not having POTS by many physicians, and that can inhibit their care. Sometimes the test isn't done properly, or the conclusion of the test isn't necessarily accurate. So I really don't do a lot of tilt table testing personally to manage and treat these patients. There are also other forms of autonomic function testing, like a sweat box test and this breath holding test, things like that get done in autonomic dysfunction laboratories. And they're looking for sort of a spectrum of autonomic dysfunction, which can be useful also because they can detect other forms of dysautonomia that are not POTS. But that's also something that I don't really rely on personally or send patients for that testing. So,
Gotcha. For the people that you're pretty confident have POTS that have come back negative on those other tests, do you think just all the conditions are right in that moment? Like their sodium level and their volume, like all the conditions are good and that's why it came back negative? Or what do you think are the reasons why they might get those false negative results?
There's a lot to do with volume, medications, right? So if patients are being treated for POTS and then they go do this test and they're taking a beta blocker or they're taking some medicines that help with volume expansion, then they're not going to have an abnormal result. So usually we tell patients to stop their medications for several days prior to testing. If the test is done first thing in the morning when they're fasting and they haven't had anything to drink, then it's more likely they're going to have an abnormal test than, let's say, later in the day if they've been hydrating well and doing everything they're supposed to be doing, wearing compression, etc. Also, I find that female patients with POTS have fluctuations in symptoms around their cycle. So usually they're much more symptomatic prior to their period. So if they're getting tested prior to their period, the test is probably going to be abnormal. But maybe if they get the test done a week later, the test would be normal because their volume status is sort of shifted. So there are a lot of reasons why the test may or may not come back positive. And that's another reason why, it gets complicated to order it.
You kind of touched on a couple of these, but if someone gets the diagnosis of POTS, what are some of the initial treatment recommendations that you'll make? And then if those don't work, then what do you go to? And if those don't work, then what do you go to? What's your process?
Hey guys, I'll get back to the episode in just a second, but I wanted to pause to let you know that if you love my podcast, but wish there were more of these awesome episodes, well, I have great news for you. There is more. My Rapid Response Academy is basically podcast 2.0, plus the huge added bonus of community. I love hosting this podcast, but it's just me, recording into a microphone often by myself. And this extroverted gal who loves to both teach and mentor nurses just wanted more. So in the community I created, I get to teach live every Friday and break down topics that I think every nurse needs to know. From deep dives into the pathophys of every emergency you can think of, to some of the heart of nursing topics as well, like how to advocate with confidence for your patient, how to de-escalate situations, how to deal with bullies on the unit, how to be an amazing preceptor and charge nurse, and some of the mindsets and boundaries that have helped me stay in nursing for the last 20 years, not burn out, and thrive at the bedside. I love the opportunity to answer your questions live, and it's such a joy to see nurses supporting each other in this community. So, if you're an acute care nurse that wants to expedite your growth as a nurse and invest in yourself so that you can provide the best care to your patients, you would love my Rapid Response Academy. So to learn more, I put a link in the show notes for you. Hope to see you there.
It's a major process. And I think that's why a lot of physicians are scared of taking care of patients with POTS or don't really, quote unquote, understand POTS, because there's a lot of trial and error involved for taking care of these patients. The first line treatment for POTS is increasing fluid intake. So lots of water. We recommend over 90 ounces a day. But in combination with increasing salt, if you only drink water and you don't increase your salt intake, then you're not going to expand the intravascular volume correctly. So we encourage patients to also increase salt intake, and we'll recommend anywhere from 3 to 10 grams of sodium, depending on sort of their blood pressure and what they're looking like when they come into the office. And then compression. So there have been studies that shown that abdominal compression actually works best, like an abdominal binder, but we find that lower extremity compression is very helpful. And we often recommend compression that goes all the way to the waist or at least to the thighs, along with an abdominal binder. Some patients can't tolerate compression because of heat intolerance issues or tactile sensation issues. And so, there's sort of other ways we can try to compress the blood vessels, but usually, the compression socks or garments is the first line. Then we do recommend exercise for all of these patients. However, some of them can't really exercise without going on to medications. The exercise we recommend is sort of low level, low impact, very slow progression, along with strength training, especially the lower extremities. And we use different exercise protocols that we recommend for patients. After that initial sort of treatment, then in addition to sort of focusing on some mast cell things, I like to start patients on antihistamines and talk to them about avoiding triggers, mast cell triggers specifically, in that initial meeting, so that we can see if that's a component of their POTS, if treating that helps settle down some of their symptoms. Then we move on to medications. We look at, things that expand blood volume like Florinef and DDAVP. We look at medications that increase blood pressure like midodrine. That increase in blood pressure will cause a drop in heart rate just to compensate for increased stroke volume and cardiac output. Then we look at medications that control heart rate, beta blockers, calcium channel blockers, and medications like Corlenor, which is a funny channel blocker. Second line after that is sort of like your clonidine, which also regulates heart rate and sort of keeps things stable. Pyridostigmine, which is a sort of a drug used in patients with myasthenia gravis, but it has some parasympathetic activating properties, and other sort of second, third line medications and treatments. My last resort is IV fluids, which I really try to avoid, because once patients start getting regular IV fluids, it's hard to get them off of IV fluids. But in some cases where patients truly have severe gastroparesis or cyclical vomiting, or they just can't take any volume or food in by mouth, it's necessary to rehydrate them and get them volume up so that they can try to, use their GI tract. So in worst case scenarios, I'll start patients on IV fluids, but that's sort of like an overview.
Right. Right. And I'm sure it's patient specific, and they all have different responses in the therapy that you're doing to kind of help guide therapy in the future. It sounds very complicated. So I'm so grateful there's people like you that are willing to kind of take on for the long haul caring for this patient population. It's not just like a one clinic visit and we fixed it and you're good to go. There's some tweaking, I'm sure, to be done.
Yeah, I would say that this population, the number of patients that come to me and say, I don't like taking medications because I have adverse reactions to every medication I take is very high. In fact, when people tell me that, I tell them, yes, you and every other patient with POTS that I see, even though patients feel like they're alone in that and that their bodies are very sensitive. It's true because usually of the mast cell activation component of this. And many of these patients have reactivity to the inactive ingredients in drugs. And so trying to figure that out and trying to figure out which inactive ingredient makes them, have adverse effects can be helpful in terms of targeting therapies. But that is what creates a lot of trial and error in this population of patients really trying to sort of hammer down what their intolerances are and what they can tolerate in terms of management. So it is a lot of trial and error and a lot of office visits, unfortunately.
Sure. Is there any current research surrounding POTS that you find particularly promising or exciting?
Well, I have a special interest personally in pelvic venous disease and lower extremity venous disease. And we find, our data sort of that we've been presenting now at national meetings finds about 80% of the population of patients that come to see me have pelvic venous disease, like iliac vein or renal vein compression, along with pelvic vein dilation, pelvic congestion, but also about 80% of my patients have venous insufficiency. And so these are two areas that interest me because they're treatable. We don't have data yet on randomized controlled trials of whether or not fixing venous disease helps POTS symptoms specifically, but we have some promising, anecdotal information that it seems that many patients do benefit from treatment. But, those studies are sort of in the works. And then other things that, sort of interest me in this population are their sort of hypercoagulable state, or a lot of them will have microclots, especially patients who develop POTS like after COVID infection. And so anticoagulation or therapy towards microclotting can help in these patients a lot. And so people are looking into that as well. There are two studies going on now through the NIH that are looking at ivabradine or Corlinor, which is a funny channel blocker, and then IVIG, both in the treatment of POTS, which will be huge and lots of useful information there. So I think that the COVID pandemic has spurred a little bit more interest in POTS, which is great. And I think that there's going to be some interesting trials that come out of that, which will be very useful for the patients and for people like me who treat these patients.
Yeah, that is exciting. So going back to that case that I opened up with, if you were the provider that responded to this emergency, the POTS patient's on the ground, the wife is fanning her, how would you have responded to that situation differently than the providers that I was alongside?
So I think what's really important in the moment is to hydrate the patient. The first thing I do is put them on the ground and try to put their feet up because they've probably been pooling blood in their lower extremities, and that's why they passed out. So lying on the ground, put the feet up, pushing some IV fluids. And I often give these patients Benadryl in the moment. It seems to help sort of calm down that mast cell mediated response that we see. So either liquid Benadryl, which is a little faster acting than a pill, or an IV Benadryl if it's available if you're taking care of a patient like this in the hospital. But that would be my go-to for an acute event like that.
All right. And then as far as like advocating for these patients, I was an ER nurse before. I am sure I sent home so many patients that had POTS, and we just told them like, look, everything looks good. Go home. Wish you the best. What kinds of things would I look for to be able to maybe include the patient? Hey, you should get this investigated further because you have X, Y, and Z that I'm picking up on. How would you kind of direct nurses in that way?
I think it's really important when, sort of younger patients who come in it feels like they're having a panic attack. Everyone wants to call it anxiety. But those patients usually get a D-dimer. The D-dimer is usually abnormal. So they get a CT, scan to look for PE.
Which is negative.
It's negative. And they sort of wonder why the D-dimer was abnormal, but not so much. And they get sent on their way. And, that's about it. But these patients should really have orthostatic vitals taken. So you really want to do lying, sitting, and standing blood pressure, and standing then after a minute or two, not just initial standing, but give it 3 to 5 minutes to see if they do have an orthostatic response or if there's tachycardia, with standing. That's definitely helpful because if you have that, if you can see POTS or diagnose, this greater than 30 beat per minute increase in heart rate, then you can inform the patient that they have that and they should probably be evaluated for it. I would always recommend giving these patients IV fluids. I think that sometimes gets missed. They get labeled as anxious, and what would really help the patient in the moment is 1 to 2 liters of normal saline just to get them sort of back calmed down, in addition to things like Benadryl and Ativan, which both help stabilize mast cells and treat a histamine-mediated response. So, or IV benzo of some sort, right? So doing those things helps the patient in the moment. But I think that just recognizing that this is an issue and that this does cause sort of emergent symptoms or emergency feeling symptoms is important. And it's not, I just think that we overdiagnose people with anxiety and panic. And these patients certainly have anxiety because they have episodes that are causing significant symptoms. And I would have anxiety too if this kept on happening to me. And so if it's not dismissed, and if someone is there providing some validation that this is actually a real thing and it's not just a panic attack, I say not just a panic attack. Panic attacks are real too. And those are things that should be treated as well. But that there's something else going on, I think that's very helpful for a patient coming into the ER or seen in the emergency setting.
And, I worked in the ER 10 years ago. It's been a while, but if I was working there now and I had a patient with these symptoms, I think I would print your journal article and highlight, here's some easy over-the-counter stuff you can do to help your symptoms. Try this out, see if it helps. Go see a professional, have them work you up a little more fully than this quick ER, 1 hour stay. But yeah, it really does kind of it's heavy on my heart to think of all the patients that I probably sent home that really did have something going on. And we as a healthcare team kind of dismissed it because we didn't find anything blaringly obvious like a pulmonary embolism. And we said, looks like it's just all in your head. You should go home and take a rest, calm down. Oh my gosh, it just upsets me so much.
I think that happened more 10 years ago than it does now. Although most of my patients will tell me that they don't go to the ER anymore because the ER doctors don't know what to do with them and don't know what's wrong with them. And a lot of them will dismiss their symptoms, et cetera. So many of my patients decide to avoid the ER on purpose because they are very frustrated with the care that they've received there. So any kind of validation of symptoms and, understanding that this is real and understanding what POTS is even is helpful for those patients who are showing up for emergency care.
Dr. Cutchins, I want to be mindful of your time. Thank you so much. Before I let you go, do you have any other pearls of wisdom, advice for healthcare professionals when it comes to caring for patients with POTS?
Oh, gosh. I don't know. Just a little bit more of what we've been saying, which is listen to them. I would say the most that I've learned about managing patients with POTS has come from listening to patients and what they think that they need and what they've read online or what they've heard about. It's not all wrong. I spend a lot of time looking things up that patients have brought to me to see, is it valid? Is it reasonable? Should we try this? And I've gotten very far with that. So I think a lot of times physicians sort of will be upset when patients come to them with their own thoughts on their illness. And I think the internet is a very valuable resource these days. And it's not all, fake. I mean, there's a lot of very, very valuable information out there. And these patients spend a lot of time looking for reasons why they're having the symptoms they're having because no other doctors can find something wrong. So I think as a physician, as a nurse, as a provider, a healthcare provider, it's valuable to listen to what they have to say and, make your own judgment, not in the moment, but after you've thought about it and researched it a little bit yourself.
Absolutely. Amen. Dr. Cutchins, thank you so much for your time. This was wonderful. I can't wait to share with my audience. Have a great rest of your day. So appreciate you.
Thanks so much for having me.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.